All right. Good morning. I have to use the microphone now. Can everybody hear me? I'm pretty loud with that one. But thank you so much for coming to our lovely Medicare add-on that we have. I am thrilled that we were able to do this. So thank you, Geraldine, for being here. I've never met anybody who can make Medicare exciting, interesting, fun. I could probably use a couple other adjectives, but very excited to have Geraldine here. She's been a longtime friend, as well as a supporter of NAMAPA and the Healthcare Advocate Summit. So I'm going to set the stage for her. She knows a lot. Write your questions down. Make sure you ask them. She's also here for the next several days. So find her, ask her questions. She loves this stuff, guys. I went on a vacation with her this summer where I should have been taking in the sights, and we talked about Medicare while we were walking through Italy. I'm not kidding you. So when I say ask her questions, please ask her questions. So please enjoy this session. There will be 2 breaks within this. It's a 3-hour block. So we'll go for about 45 minutes, pause, go for another 50 to an hour, pause. So we will let you get up and get coffee and that kind of stuff. We won't just keep you in your seats. But appreciate you guys being here. And I'm going to give this to Geraldine. Let's go.
Thank you. I really hate having to hold this mic because there's nothing I hate more than karaoke. And that's what I feel like I'm doing right now. So it is true that we went hiking this summer and I did talk about Medicare. We had some long days. So, and just like random things just pop into my head. I have like this ADHD brain. And it even happened to me yesterday on the plane. Like I was like, what is the railroad board anyway? Like, and it prompted me to start going down that rabbit hole. And so you're going to see on one of my slides, I've got a picture of what the railroad retirement board card looks like. So anyway, so I'm Geraldine. I'm a pharmacist by trade. I've been a pharmacist for about 25 years. And you're probably asking yourself, like, how did I get into Medicare of all things as a pharmacist? So actually, I went into the Air Force right out of pharmacy school. And then I worked for the military, one branch or another, like either as active duty or civilian until about 2014. So for about 15 years, I worked for the military. So I had no concept of insurance or anything. And then I started, but I've been an oncology pharmacist since I went into the military. So when I got out, all of a sudden, I found myself faced with these big, expensive oncology drugs like Yervoy and Opdivo, Keytruda, and patients who were like not showing up for chemotherapy. And so, anyway, long story short, I got into patient assistance thanks to an FRM that was very patient with me and taught me the patient assistance process. But through that, I had to learn about Medicare, and I just absolutely could not grasp it. I could not figure out the difference between a supplement and a Medigap and an Advantage plan, and it was just so overwhelming for me. So I decided to I was looking online for like resources that I could learn Medicare from. And like I thought for sure there had to be some sort of online course that I could enroll in. But I came across the SHIP courses, which we'll talk about in a minute. But the where you can volunteer for SHIP, and you can do new to Medicare counseling for patients who are about to turn 65. And so you give them 4 hours of your time every week. In exchange, they give you all this training in Medicare. So I was like, well, why not? What's the worst that's going to happen? So I went ahead and I did that. That's how I learned Medicare, was actually working with other volunteers who had been doing it for like 20 years or whatever, and would run into all of these little weird scenarios. And So it was just kind of like uh, my dedication to not letting Medicare beat me. I just couldn't stand it, that I couldn't conquer it. I went to pharmacy school for 6 years, for the love of God. So, anyway, so that's how I ended up in Medicare. And then after that, I just felt like, why doesn't everybody else have access to this information? And like, I think it's because, even now when I'm like researching and trying to put this workshop together, there's just like this overwhelming amount of resources online. How do you package it all up together to make it understandable for people? And I'm not going to promise you that I've done that today. I tried, but even as I was like reviewing what I've done, I'm like, it's become all jumbled in my head again. So hopefully I've at least halfway have broken it down into an understandable format or organized format. So I have no conflicts of interest associated with this course. I don't work for CMS. That's for sure. A lot of learning objectives. Honestly, really what I want people to be able to walk away with is, like, if you are working with a patient who's 64, I want you to be able to say to that patient, hey, what are your plans next year? Are you going to retire? Are you going to keep working? Are you going to collect Social Security? Are you going to stay on your wife's insurance? And to be able to give them, some answers and not feel as confused as the patient. So, um, because I know that was the benefit of volunteering for SHIP, was that I started being able to see those 64-year-old patients and being able to at least nudge them to say, hey, you've got to start making some decisions soon, because if you don't do anything, you're going to be faced with these late enrollment penalties. So, got to make some decisions. So, we're going to go through Social Security a little bit. We're going to go through each of the parts of Medicare. We're going to compare the Advantage plan to the supplement. We're going to go through enrollment periods and late penalties. I want you to be able to identify the patients who we can enroll in Medicare savings programs and low-income subsidies, who's eligible for medication assistance programs. We'll touch just a little bit on coordination of benefits. And then if we have time, I'd like to show you all how to use the Plan Finder tool online, because it is so useful. And even just having some working knowledge of it and being able to show patients how to use it is just such a great resource. Okay, let's see if I can read my own slide. I don't know if it's okay. So we're actually going to get into this later, but just this basic question: what do I need to do to get enrolled into Medicare? Unfolds into this. This is how complex it is, because there's a lot of questions that have to be answered to tell you what do you need to do. There could be no steps, there could be multiple steps. But what's unfair is that the patient doesn't have access to any information about what to do. They might get a mailing of my Medicare and You handbook in the mail, and that's about it, unfortunately. Throughout so I did try to make it fun. I'm not going to say it's fun, but I tried to make it fun with some little mini Medicare quizzes. And then I snuck in there, like, if this is really around enrollment periods and late penalties, but if they make the wrong decisions around enrollment times, they could really set off some landmines that lock them in to late penalties that can cost them thousands of dollars, tens of thousands of dollars for the rest of their lives. So we'll go through some of those potential landmines later on. Okay, so SHIP. SHIP is the State Health Insurance Assistance Program. This is where I volunteered. They provide free Medicare benefit counseling in every state. They assist with the initial enrollment, and they also assist with open enrollment every year. They do not collect a commission from any patient. So there's no high pressure sales tactics. They don't call patients during open enrollment time. They're not brokers. If this would be the one resource that I would feel very comfortable across the board in any state referring your patients to if you're unsure what to do in any scenario. When I volunteered there and I was unsure what to do and I would call CMS, CMS would route the phone call back to me at SHIP. So, yes, ironic. So that's why SHIP is trusted so very much among CMS and just among the Medicare community in general. Right now is just a horrendous time of year for the patients. Some of these brokers are calling patients 20 times a day, and the things that they tell patients is also horrendous. Like, your doctor doesn't care about you. You can get them all set in a plan only to have them lure them with a meal and a $15 gift card while they sign them up for their plan at Walmart somewhere. It's really ridiculous. So, and it's frustrating for me as someone who genuinely want to allow the patient to have some decision-making capacity in the middle of all of this, and allow them to come to that decision just to have a broker persuade them with a $15 gift card is very frustrating. But anyway, here's how you can contact SHIP. And these slides are going to be available to all of you after the course as well. Okay. So just a little history of how Medicare has kind of progressed across the years. It was introduced in 1935 with President Roosevelt. And then President Johnson actually founded Medicare in 65. It was expanded in 72, further expanded in 96. Medicare Part D was founded in 2003. And then the Affordable Care Act then came in and provided preventative services for everyone. There's some major challenges that face our seniors. We've got 10,000 new patients turning 65 every day that are aging into Medicare. So that is a significant portion of our patient population, and it continues to grow. And it's putting a lot of pressure on our healthcare system. I think what is alarming is that almost 50% of our seniors live on less than $26,000 a year and have less than $15,000 in their savings. And I think that that is very in line with what I saw when I was working directly with patients in the infusion centers and signing patients up for patient assistance programs. And when I would have to get documentation from patients about their income, a lot of times all they would provide me was their social security statement. And oftentimes they didn't even make enough money to file taxes. And it always made me wonder, like, how do these people make enough money to live off of? I don't understand. But I think what you see is, the working poor usually tend to turn into the elderly poor. So, but medical bills for older people, I think like everyone else, they skip buying groceries, they delay rent, mortgage payments, or go paying utility bills. And sometimes they have family members to help them out, and sometimes they don't. But the financial challenges are faced disproportionately by older Black and Latino people. And currently, our healthcare system for seniors is a confusing patchwork of Medicare, Medicaid, and personal finances kind of slapped together. So, which brings us to Social Security and the fact that 50% of, no, I'm sorry, almost 90% of our seniors live on Social Security alone. So, what is considered full retirement age for Social Security now? And now it's no longer 65, it's 66 and a half. And so, how many people actually wait until full retirement age to claim Social Security benefits? As you can see, almost 35% start claiming Social Security at age 62. And it is based on the highest paid 35 years, working years. Again, it provides 90% of income for 25% of our seniors. The two main reasons that they collect before full retirement age is financial need and poor health. This is what is shocking for me. The average Social Security payment is $1,800 a month or $22,000 a year. The max benefit you can get is about $3,600 a month if you take it at full retirement age. And then the average disability Social Security check is about $1,500 a month. So I'm not sure if anyone is aware of how low that is, or that seniors were living off of that little money. And it was just shocking to me. I think, we tend to think seniors have pensions, but with the transition to everybody using a 401k and, not everyone is able to have enough money to save for a 401k. So they're relying on Social Security. We'll skip that, but just know there's different levels. There's supplemental Social Security income on top of it that can be used. So then what happens if they're collecting full retirement income at age 62 and Medicare doesn't kick in till age 65? What do they do for health care in the meantime? Well, Medicaid, if they're eligible, um, which depends on their whatever percent of the federal poverty limit, they can possibly get coverage through their spouse's employer. Maybe their previous employer offers retiree benefits, Cobra, but Cobra is extremely expensive. And then the other option is the Affordable Care Act. So again, here's my railroad retirement board. Um, I didn't go too far down the rabbit hole. All I'll say is that the benefits are a little bit higher with the railroad retirement board. Their taxes are higher, so they pay into it a little bit more, so their benefits are a little bit higher. And same for disability. Okay, so here's the first quiz is individuals who have been receiving Social Security or railroad retirement disability benefits for 24 months are entitled to Medicare, but also must apply to enroll in the program. True or false? How many people think it's true? How many people think it's false? You're right. So the waiting period is 24 months, and then they're automatically enrolled in Part A and B. And then they do have to sign themselves up for a Medicare Advantage plan or a Part D plan, but they are automatically enrolled in Parts A and B. Okay. Now I'm going to fully admit that I also, coming out of the military, had difficulty understanding the difference between Medicare and Medicaid, but these are two entirely different programs I learned. Medicare being a federal program, Medicaid being a state funded program with some federal help. All I'll say is that Medicaid becomes even more confusing because there's the spend down component to it, which I won't get into, but you know, those two programs can work hand in hand together for seniors, and Medicaid can oftentimes be a really good resource. Okay, so now let's start getting into the Medicare coverage basics. We've got Part A, Part B. There's really no Part C. I hate that they call it a Part C. It's a Medicare Advantage plan, and then there's Part D. So here's our Medicare costs for 2023. Part A is the premium. It's free if you have worked 40 quarters or 10 years. If you haven't, if you can see the breakdown of what the cost is if you've only worked 30 to 39 or 29 or fewer. The deductibles are quite high for Part A, so it's $1,600 every time they have a new inpatient stay for that coverage period. A coverage period for Part A is every 60 days. So if they are discharged and then 60 days later are readmitted, they have to pay that Part A deductible once again. If they do not have a Medigap or supplement plan. The Part B monthly premium is $164.90. That is automatically deducted from their Social Security check or Social Security payment. If they have deferred their Social Security payment until full retirement age, they are sent a statement and they have to then mail in their payment. The deductible is $226, and if they don't have a Medigap or supplement, they have this unlimited 20% coinsurance. So this is where you find quite a few people who might have started collecting Social Security benefits prior to the age of 65, automatically get enrolled into parts A and B, don't know that they have to then enroll themselves into a Medicare Advantage plan or a Part D plan, and then are stuck with this forever 20% coinsurance and have nothing to help pick up that 20% or the deductibles from being admitted inpatient. And then the Part D premiums, the national average premium for Part D is about $32 a month. The maximum allowed deductible is $505 a year. And then Part B premiums, what's called IRMA, and now I can't remember what IRMA stands for. Darn it. I had it on a slide and I forgot. But basically, this is if you have higher income, you're going to have additional Part B. Oh, it's income related monthly adjustment amount. It's right there in the third. But that is what is added to your Part B premium on top of the $164.90 every month. Okay, so this is just kind of for your reference. These are the co-insurances, co-pays that go along with Part A if they're hospitalized or have to go to a SNF. We don't have to go through each and every one of these. Again, this is the Part A benefit period, just an example. So they're admitted on March 1st, they get discharged March 9th, then they get admitted on May 9th. Now they've just started a new benefit period. They've got to pay the $1,600 deductible again. Okay. Second quiz. A patient is required to pay the Part A deductible every time he or she enters a Medicare participating hospital. Yeah, that's kind of a given. It was a bad question. It's every 60 days. Okay, Part B is outpatient coverage, but outpatient coverage is really kind of a general term. So what all is included in outpatient coverage? So you can see what's covered under Part B is the annual physical exams, labs, DME, mental health, ambulance services. What's not covered is long-term nursing home care for more than 100 days. And then all of the things that seniors need, like routine foot care, because so many of them are diabetic, hearing aids, dental, and vision. Although there are additional policies that you can purchase that go along with a lot of the Medicare Advantage plans, but they do not come standard with Part B. So if you end up getting a supplement, you lose out on many of those things. Okay, and then Part B also is what covers your injected and infused medications across several different settings. So your hospital outpatient infusion centers, your physician-based office infusion centers, home health, dialysis centers, And the other one would be the independent infusion center suites as well. We can skip over assignment. Okay. The Medicare, oh, this is a good quiz for myself. The Medicare higher income related Part B premiums for higher income beneficiaries are called what? Part B, I thought this was clever. Part B Premium Plus or IRMA? All right, it's IRMA. Okay, Part D. When it comes to Part D, the pricing is so complex and it's dependent on so many different things. And this is another area where patients could really get themselves in a lot of trouble if they don't look at, if they don't go to a in-network pharmacy, a preferred pharmacy, if their drugs aren't on the formulary, or so these are all the things that make up the Part D medication pricing. If it's a brand or generic, whether it's brand or generic is what dictates where it falls on the tier level. Then dependent upon the Part D or the Medicare Advantage plan, whether that drug is formulary, then whether that pharmacy is in or out of network, or whether it's a preferred pharmacy or not, and then where that patient is at in their coverage phase. So are they in their initial coverage phase? Are they in the coverage gap? Are they in the catastrophic phase? All of that makes up the cost. The Part D prescription drug tiers. So the specialty medications fall into the highest tier. Your non-preferred brand medications fall into tier 3. Your preferred brands are tier 2, and your generics are tier 1. And this is where the Medicare Plan Finder really comes in handy, because you're able to basically type in your zip code. You can then enter in all of the patient's medications, and we'll go over this in a minute, but even if you lose, or even if you miss entering in one medication, your estimate could be off significantly. So I really encourage people to use the Plan Finder tool. So this is just, this actually came from Consumer Reports, where they evaluated several Part D plans at pharmacies in 6 different zip codes for 5 common generic drugs. And you can see how different the prices are. So I live in the Seattle area, and based on all of those factors that we just talked about, the drug prices could be anywhere from $450 to $1,200. So that's what the range could be. And that's how much you could save your patients if you were to use the Plan Finder tool, plug in all of their drugs, make sure they're going to the correct pharmacy. You could end up saving them a significant amount of money. Again, make sure you include everything. This is just showing this is what happens when you leave off the cost of one drug. This should be 2023, the typo on my part. And this is really going to not be significant next year because with the Inflation Reduction Act, that catastrophic coverage phase is going to go away in 2024. And then in 2025, the cap overall is going to be $2,000. So starting January 1st, 2024, the catastrophic coverage stage is going away. So once they meet that $7,400, and that $7,400 is a combination of what the plan pays and what the patient pays. But once that $7,400 is met, then the patient doesn't pay anything else for the remainder of the year. Then in 2025, the patient will pay the 25% in the initial coverage stage until they hit $2,000. And then $2,000 will be the coverage gap. And then they won't pay anything else for the remainder of the year. Except for, it won't be 25%. It will be that smoothing effect, which I have to read up on how that actually will break down. I'll get back to y'all. So this is just a little bit more about the timeline for the Inflation Reduction Act. We've already seen the insulin capped at $35 a month. Cost sharing is eliminated for vaccines covered under Part D. The 5% coinsurance that coinsurance is eliminated in 2024. Also in 2024, the low-income subsidy is going to be expanded to those who would only qualify for the partial low-income subsidy. That partial will be eliminated and everyone will qualify for the full low-income subsidy. Then in 2025 is the $2,000 out-of-pocket limit on Part D costs. And then in 2026 through 2029 is when the Medicare starts negotiating the drug prices. Hopefully. Yeah. And here's the first 10. We won't go through them. It's to be seen. I don't know if it's lawsuits are already being filed. So, I'm not sure if it's going to happen or not. I don't know. Jordan, what do you think? Get started again. Pick back up with Medicare supplements. So it took me a very long time to realize that Medicare supplements were the same thing as Medigaps. I'm not sure why this was hard for me to grasp, but it was. So patients have 6 months from the time they turn 65 and have Part B to enroll into a Medigap program without being subject to medical underwriting. So they cannot be, well, I don't want to say excluded, but because they can always enroll in a Medigap program, but their premiums will not be sky high. This is kind of like a once in a lifetime opportunity to enroll with reasonable rates during this initial enrollment period for the Medigap program. However, there is like a not well-known secret that if a patient is unhappy with their Medicare Advantage plan when they first enroll, they can switch to a Medigap plan within 12 months of first joining that Medicare Advantage plan. That's a one-time opportunity as well. Yep. So during the initial enrollment period, if a patient enrolls into a Medicare Advantage plan and they're unhappy with that Medicare Advantage plan when they first enrolled, they can actually switch to a Medigap without being subject to medical underwriting within 12 months of first joining that Medicare Advantage plan. And that is not well known and not utilized very often. Also, the supplements cannot be used in combination with the Medicare Advantage plans, which I get asked about a lot because a lot of the Medicare Advantage plans, which are more and more patients are enrolling into Medicare Advantage plans, but these also come with high out-of-pocket maxes. So I think the average for 2023 is like $7,500. So people want to know, can they enroll in a Medigap plan to pick up that $7,500? And the answer is no. The Medicare supplements, they only cover services that Medicare A and B cover. So they're not going to cover vision, hearing, and dental because Part B doesn't cover vision, hearing, or dental. And then we'll look at this in a minute, but each lettered plan, so there's, I can't remember how many letters plans there are. Each letter plan must offer the same benefits despite the difference in the monthly premiums. So you can have 13 different plan Gs in an area. You can have a plan G that costs $100 a month and a plan G that costs $200 a month, and they have to offer exactly the same services. So it benefits the patients to shop around. So here's the comparison chart. So we've got 10 different supplements. Okay. So all plan Gs, again, have to offer the same thing, regardless of price. Plan F and Plan C are no longer available unless they were eligible for Medicare Parts A and B prior to January 1st of 2020. So the next best plan, we call it the Cadillac plan, would be Plan G. And the only difference between Plan G and Plan F is that Plan G does not pick up the Part B deductible, which is about $200 and some. So Plan F used to pick up that deductible and Plan G does not. So typically what I do is I use the Medicare Plan Finder tool, and I will type in the patient's zip code and I'll find all of the available plan Gs or whatever I'm looking for. And then I go to those plan websites and I get an estimate on behalf of the patient. And I have actually gotten several patients into Plan Gs for $80 to $100 a month. So it's just a matter of doing the legwork of shopping. It's a little more work up front, but honestly, you can lock them in for the rest of their life at that rate. So it's a significant savings. So, because the argument is a lot of patients don't think they can afford a supplement, but they actually can. There are supplements out there that they can afford. And then Plan N would be the next best thing to Plan G. And the only difference between N and G is that N doesn't pay the excess charges for Medicare. Excess charges. So here, this is just an example that I took from SHIP, where this is in the state of Virginia, showing the difference in the Medigap plans. So you can see if we looked at Plan F, and the very top one is NAIC, and no, that's not a good one because it's broken down into male and female. We look at NAIC, the second one, for $1,800, and that's per year. And then we look at the next line down, NAIC is $1,500 per year. So, and then the next one down is $2,000 per year. All three of those plans offer exactly the same thing. Okay, next quiz question. So you must go to that supplement, aka Medigap, plans network providers for your care. You may not choose your care with a supplement or a Medigap. True or false? Correct. That is one of the big bonuses of using a supplement, is that Medicare A and B, you can choose your providers. Okay, Medicare Advantage. I'm going to need some water before I start talking about this. Okay, I decided I'm going to tell you another secret that they don't tell you, because I think you all are nice people. And I feel like you have good intentions. So the other secret is that there is a time when, outside of open enrollment, when you can enroll a patient or change Medicare Advantage plans. So let's say you've come across a patient who has just Medicare Part A and B only, and you want to get them into a Medicare Advantage plan, but you're outside of the open enrollment window. If there is a 5-star plan in that patient's area, you can enroll patients into a 5-star plan any time of year. Yes. Actually, so I'll tell you, I did this for my father because my dad didn't know that he needed to enroll past the Medicare Part A and B portion. And he ended up being hospitalized for an appendectomy. and he's also a heavy smoker and was a heavy drinker for a long time. So when I found this out, I was like, okay, he's definitely not getting into a supplement. So the next best thing is a Medicare Advantage plan. And it was outside open enrollment. And so I did some digging and I found out this little tidbit that you can enroll any time of year into a 5-star plan. Now, not every location, not every county offers a 5-star plan. That's the problem. But I have used this resource several times because there are so many patients who don't know that they have to do their own enrollment past the Part A and B portion. And they think it's automatic. So, yes. That's a great question. I'm going to look that up. I would think the answer is yes, because you can enroll in a 5-star at any time of year, but I will get back to you. Yeah, it's a good question. You private patient advocates stump me every time. Oh, were you? Yeah, private patient advocates every time. Okay, Medicare Advantage plans. This is where we have just seen massive growth in Medicare. The enrollment into the plans has tripled from 2005 to 2015. This is where CMS contracts with private payers to provide the same benefits as Medicare A and B, plus or minus Part D. The private payers receive a lump sum from the federal government for each member in their plan, so they're incentivized to lower the cost and provide value-based care. Star ratings hold the plans accountable by tying their scores to bonus payments. So it's supposed to be high value instead of high volume care. So this is just kind of showing the trajectory of enrollment into the Medicare Advantage programs over the last, 16 years? So we're at 50%, and they're expecting the trend to continue. So why are they so enticing? Well, there's no out-of-pocket maximum with traditional Medicare A and B. And what I mean by is there's that forever 20% co-insurance. There's no stopping point. And so to the patient, it appears like it's a benefit to them. Especially when you combine that with what the brokers say, no premiums, when we know that they still have to pay the Part B premium, but that's the way they sell them, as $0 premiums. So that out-of-pocket max looks protective to the patient. However, I do think this is a benefit where more plans are providing those, this word is confusing, supplemental benefits, including long-term care services and nursing homes. Because some of these have become the default care settings for older adults at the end of life. And they also provide dental, vision, and hearing. And we sometimes underestimate the importance of those services for seniors. It started that way, and every year it's getting better and better and becoming more valuable. But the Medicare Advantage programs are starting to build up home care resources so that patients can age in place. That is the goal. I just picked out 3 of the most popular Medicare Advantage plans or types of plans because there are so many of them. And not all of them are offered in all locations. But the top 3 are the HMO, the PPO, and then the special needs plans. And the special needs plans now have accounted for 2/3 of the Medicare Advantage plan growth in 2022. The majority of those special needs plans are the dual eligible for Medicare and Medicaid. But some of these special needs plans offer some additional benefits not covered by traditional Medicare, like OTC meds, transportation, meal benefits. I don't know what remote access tech is. Oh, gotcha. Yes, that's true. Yeah. Mhm. Um, and I know some of the patients that I have helped enroll into Medicaid where they ended up becoming dual eligible. All of those things were so useful and valuable to those patients. Like the I really overlooked the value of the OTC meds. So, and transportation. And when I kind of dug down into it, here I was working in an infusion center all day long, not knowing how many patients we had to coordinate transportation for. So, and then again, as far as the income, I had the very first patient that I signed up for Medicaid had Crohn's disease, and she was living off of $9,800 a year. And I was thinking, how in the world is this lady making it? She was 68, and she could never hold a job long enough to be able to pay into Social Security to be able to collect a significant amount of benefits. So things like the meal benefit was really important to her. Okay, so this is just comparing Medicare Advantage to supplement, but I think it sounds like you all are much more familiar with Medicare Advantage plans and supplements more than I was. This is just showing some of the extra benefits that the Medicare Advantage plans have. versus the special needs plans. And I think the transportation is one of the big benefits of the special needs plans that is standing out. This has been a topic of, I would say, controversy for a while now, is the number of prior authorizations that the Medicare Advantage plans require. And I think that there is some legislation in progress that is trying to require the Medicare Advantage plans to have to turn around and answer at least for the prior authorizations within a certain time frame, because a lot of times the prior authorizations can hang out there, depending on the plan, for 7 to 10 days or even longer. So, but this just, I thought, was a good representation of, I mean, this is just a small snapshot of the number of services requiring a prior authorization. I love the first one is some services. And then the second one is durable medical equipment, Part B drugs. So that's really where your infusions and injections sit, and it's really cumbersome. The Part B drugs is very problematic. Then the skilled nursing facility stays, inpatient hospital stays, diagnostic procedures, partial hospitalizations, physical therapy, diabetic supplies, opioid treatment, just the list goes on and on. Yeah, yeah, yeah. Which is odd, because I thought, as part of the Affordable Care Act, that's supposed to be included.
Not do the right one. Say, yeah, I forgot what I was going to say. I'm sorry. She had a question.
I can't tell you how many times that happens to me in a day.
Yeah.
Okay, so then this is what we show all of we call them NTM, new to Medicare patients. We kind of lay this out in front of them to explain to them, here are your two options for Medicare. You can have Part A and B, and you can add a prescription drug program, and you can add a supplement. So it would be A and B plus or minus. Part D, maybe you have retiree benefits that offers you prescription drug coverage, so you don't need Part D. Maybe you need a supplement, maybe you don't. Or you can go the route of Medicare Advantage plan, which is A, B, and there are some Medicare Advantage plans that do not have a Part D plan wrapped up in it. So that's an option as well. Okay. So the next question for my quiz is, Bob's out-of-pocket maximum for his Medicare Advantage plan is $4,300 per year. The prescriptions Bob has filled throughout the year contribute towards his Medicare Advantage plan's $4,300 out-of-pocket maximum. True or false? This is something that people also get confused about, even with the supplement and a Part D plan, or your Part B expenses and a Part D plan. Oftentimes think that their medical expenses contribute towards their Part D out-of-pocket costs and vice versa. Sure. Somebody have a question? So this is even too tiny for me to read, but my point with this is, what do I need to do to get enrolled in Medicare? If a patient were to ask me that, my first question would be, are you collecting Social Security benefits or not? Because if they are already collecting Social Security benefits, they don't need to do anything. They will receive their red, white, and blue card in the mail about 3 months before they turn 65. If they decide that they want to continue working past the age of 65, or it's then they want to stay on their spouse's insurance, or they want to stay on their own, they have their own employer insurance, they will have to decline the Part B, and they will get the Medicare card in the mail, and they actually have to decline it and send it back. And if they don't do that, then they'll actually start paying it. The Part B will start getting deducted from their Social Security benefits, or they will get billed for the Part B. Let's see if I can. Okay, so if they are already collecting Social Security benefits, they will automatically be enrolled in Parts A and B, but they will need to enroll themselves in either a Medicare Advantage plan, Part D, or a supplement themselves. If they're receiving Social Security benefits, but they don't want Medicare right now because they have creditable coverage through their own or their spouse's employer, then if Part A premium is free for them, they should just continue to receive Part A, but they need to decline the Part B. and ensure that within 8 months after their employer or their spouse's employer, after that coverage is discontinued, that they need to enroll themselves back into Part B. And if they don't enroll within that 8 months into Part B, then they may have to pay the Part B penalty. So that can be very confusing for me. For a life. Yeah. Right.
So if you wait 2 years, it's 20%.
So if you delay getting Part B of Medicare, for every year that passes, there's a 10% penalty. So you wait 5 years, a 50% penalty, and so on. And so it will never be removed. And so some people who get Medicare based on a disability, and maybe they haven't enrolled in Part B timely, at age 65, they have a enrollment period for Medicare at age 65. And at that point, the penalty will drop off for those individuals. Because disability is a separate category from Medicare, which is age 65. And so another comment you made about the employer group health plan, I think it's really important to note that it's employer group health plan based on you or your spouse being a working employee. Because many companies, they retire and you can keep that insurance through retirement. But as soon as you retire and you get that insurance based on being a retiree, that window of time starts counting, where if you only have Medicare Part A, you need to go back and enroll in Medicare Part B. So that 8-month window of time is a special enrollment period. And also, all of these enrollment periods, depending on when you enroll, determines when your coverage for Medicare begins. So, for instance, the initial enrollment period for Medicare is 3 months before you're 65, the month of 65, and 3 months after. If you enroll in Medicare in the 3 months before you're 65, your coverage will begin on your birthday. If you enroll in the month of your birthday, your coverage for Part B begins 1 month later. And so, if you enroll after that, there begin delays. There's a 1 month delay, then there's a couple month delays before your insurance kicks in. So,
that delay. They got rid of that delay, so it now begins on the first of the month following when you enroll.
Yeah.
So
Okay. Just pay attention to your enroll periods for Medicare.
Yeah. Yes. It has to be 20 or more.
When you enroll in Medicare, if your employer is still paying part of it, you have to count on the number of employees that are in that company as whether or not Medicare is primary or secondary.
Right.
And that can be a huge factor in the cost.
Yes. So to reiterate, yeah, that's what I have on here in my very small print was if you don't enroll in Part B within the 8 months of that special enrollment period, then the Part B penalty is 10% per year where they're not enrolled in Part B. This is just a high-level overview of some of the enrollment periods, because there's, on the next slide, maybe I should go to that next slide first. So there's an initial enrollment period. Like this gentleman was saying, you have 3 months prior to your birthday, the month of your birthday, and 3 months after to do the initial enrollment into Medicare. Then you have the annual enrollment period, which is what we're coming up to here quickly, October 15th to December 7th. Open enrollment which is where you can change or drop an existing Medicare Advantage plan, is January 1st to March 31st. Is also the same as the general enrollment period. If this is where you can enroll in Part A or B if you missed your initial enrollment period. And then there are special enrollment periods which last up to 8 months, which we'll talk about here in a minute. Doing for time. We need to take another break. I think
Yep.
we'll write it. Yep.
All
Okay.
right, everybody, if we want to just take a short break for coffee and water and use the restroom, we'll pick back up in just a few minutes.
Okay. We're on the home stretch, people. Okay, so we went through initial enrollment period, general enrollment. So if they miss their initial enrollment period, they can then use the general enrollment period, which is January 1st through March 31st, to sign up for Medicare Part A and B. However, it doesn't take effect until July 1st. And if they find themselves in that situation, that's where there's a good chance that they will incur the Part B late penalty. And this is where I think you see a lot of situations where the patients don't know that they have to sign up for anything beyond parts A and B, or that they have to sign up at all. And then they miss the initial enrollment period, they miss the general enrollment period, and then they go years without enrolling in anything, and then end up incurring, 2, 3, 4, 5 years worth of late penalties. And then once they do get sick, or need a hospitalization or a surgery or something, find themselves needing insurance, and then when they go to sign up, find out that they have to add, like this gentleman was saying, 50% worth of late penalties on top of their existing premiums that they have to pay. So how do you sign up for Medicare Part A and B? There's 3 different ways. You can do it online through the Social Security website, over the phone, if you really want to torture yourself. However, and I know this sounds like a horrible suggestion, but we at SHIP always recommend that you sign up in person and you sit across from someone and you get copies of all of the paperwork and you document who you spoke to, the time, the date, you document everything. Because just a simple mistake can end up costing you so much money.
Have experience with Medicare signups through Social Security, but I have a lot of experience with Social Security itself. And when you go in person, like you said, they can't dodge it. You get in there, you're in front of somebody, you can ask all your questions. I always go in and I just kind of have in mind, these are the things I need to take care of. And like where I live now, it's the Social Security office is never busy, which is the weirdest thing to say. If I go and call, you're on hold for an hour or two. And then they probably just tell you, okay, well, we're going to book you an appointment for 2 months from now.
Yeah.
So when you're in person, sometimes if your office takes appointments, you can do that. But they have walk-ins as well. And then, like I said, just depending on where you live, you might actually find that there's nobody ahead of you. So it just
Yep.
depends.
Thank you. Again, so I don't know if CMS just comes up with different enrollment periods to make it more confusing, but they can't standardize the different enrollment periods. But so for the Medigap or the supplement, you've got 6 months to enroll from the time you turn 65 and when you have Part B. So it's different than the initial enrollment period. Oh, sorry. It's going the wrong way. Then there's the special enrollment period. Again, these slides will come out to all of you, but there's a few scenarios. One would be you would qualify if you lost coverage under a group health plan, 20 employees or more, that's offered by your the patient's employer or their spouse's employer, and it must be their current employer. And it has to be, the coverage had to have been from the individual or spouse who is actively working, can't be from retiree benefits ending. Or the other type of special enrollment period would come from qualifying life events, which would include something like you would move out of your planned service area, you're released from jail. I don't know how many of you have been released from jail recently. The patient now qualifies for Medicaid and MSP or extra help. Patient moved in or out of an institutional facility like a nursing home. And so they have 60 days before and after that qualifying life event to change their plan. Yes. I think we talked about this already. The Medicare Part B penalty is 10% of the premium for every 12 months that enrollment is delayed, times number of years delayed. Yeah. Oh, what's it?
Gonna say there's a penalty for Part D also.
Oh, okay.
Yeah.
Okay. Yeah. So the Part D penalty is 1% of the, it's supposed to be the, you get cut off. The average monthly prescription premium times the number of months that you didn't have Part D is what the penalty comes out to be. And so as long as you have I can't see this word, creditable coverage in place, then you won't incur the Part D penalty. And so some examples of creditable coverage are TRICARE, VA benefits, Indian Health, COBRA could be creditable. You have to check to see if your current or former employer is creditable. and whether the individual plans from the Affordable Care Act is creditable. What isn't creditable is the Medigap plans that used to have prescription drug coverage and programs that aren't actual insurance coming from like a free clinic or state programs or obviously sample drugs. Then I just thought this was kind of ironic that I found online. So I'll admit I take a lot of screenshots because there's so many resources out there online, and I just think, why would I reinvent the wheel when there's all of these things? So I take a lot of snapshots. But I just thought this was funny because when they have the Medicare enrollment checklist, this is supposed to be for a patient. So 6 months before they turn 65, they need to understand the 4 parts of Medicare. They need to educate themselves on Medicare supplement plans. They need to review additional hearing and vision plans. They need to learn how Medicare works with other insurances. And they need to understand Medicare enrollment periods. And I was like, oh, that's it? Well, that in 6 months, that should be that's nothing. So then during open enrollment, what are the changes that you can make during open enrollment? Anyone with original Medicare A and B can enroll in a Medicare Advantage plan. Anyone with a Advantage plan can drop and switch back to original A and B. Anyone with a Medicare Advantage plan can switch to a new Advantage plan. You can switch from a Part D plan to a new Part D plan. Anyone who has original Medicare A and B can join or drop a Part D plan. What you can't do is anyone in a Medigap cannot switch to a new Medigap without being subjected to medical underwriting. So they can enroll in a new Medigap plan. They can enroll in a new Medigap plan any time of the year. It doesn't have to happen during open enrollment, but they will be subject to medical underwriting outside of that first 6 months for their initial enrollment period. And same for they can't drop their Medicare Advantage plan and enroll in a Medigap plan without being subject to medical underwriting. So this is kind of, I guess, my checklist of how I assist them in the open enrollment process is I have them bring their annual notice from Medicare about any plan changes for the next year. And then we go through and make sure that the drugs are still covered. And especially make sure that the providers are still in network for them. And then we need to talk about anything that might be coming up within the next year. Do they have any surgeries planned or any major medical events coming up? Do they need a new primary care doctor? Is there, are they having a total knee replacement and the surgeon they want to see, is he in network with their plan? We screen them to see if they qualify for any Medicare savings programs or low-income subsidy. We use the plan finder tool just to make sure we have them on the most cost-effective plan. And then we just check the star rating also using the plan finder tool. Okay, so well, let's skip the quiz because I still have a lot of stuff to get through. So I have to skip my landmines. Okay, so low income subsidy, same thing as extra help. Again, the partial extra help is going away in 2024, and so everyone will qualify as full extra help. Copay for generic is $4.15, brand $10.35. They do not have to apply for a low income subsidy if they're already receiving supplemental Social Security. I think for this, I think what trips people up is also it's not just income, but also what counts towards an asset. So it's money and it's cash, basically stocks and bonds, mutual funds, real estate that's not their primary residence, and then the burial expense up to $1,500. Or I'm sorry, doesn't count up to $1,500. Vehicles don't count. Yeah. Yeah.
A whole life policy counts the value of the whole life policy.
Okay. Yeah, I don't know off the top of my head.
Pardon me?
What you need to know about that? Like, you have to catch them, okay.
For MSP or extra help or any of them, the form is pretty extensive. And so as you fill it in and you go through it, all of a sudden you have insurance. And then it'll, at least in Jersey, the Jersey form is fairly specific. And the same as New York is that it's fairly specific. And it says whole life and term. And if it's whole life, in other words, if they're in their 70s, 80s, and they bought it how many years ago, it's paid off. It might be a $50,000, $100,000 policy. Their position is you have to cash it in and use it for living.
Sure, but they're the ones that will be policies.
Sure. Policy. Should be like the phone. Yeah.
If I may, aid in attendance, the aid in attendance program, which offers tax-free benefits if you have qualifying ADLs, et cetera, that many of the states will count that income, which is tax-free, anywhere from $1,300 to $2,000 a month. They'll count that as a pure asset, cash asset, and that'll eliminate if they've been on an MSP or anything before they qualify for anything else, including Medicaid. Once you qualify for aid and attendance, they'll knock you right out of the box.
Okay, I think we can skip over this. I think my point with this slide, my tiny print on this slide, is just that there's about 3 million Medicare beneficiaries that need to be enrolled that are not currently enrolled in extra help, but would definitely qualify. So, and then I just thought it was ironic that the Biden administration, with Joe Biden's age, is doing a social media campaign trying to encourage people to sign up for extra help. Well, just he's been very progressive at his age with Medicare in general, but just with this, I just thought the irony with him at his age being progressive with the social media campaign specifically for extra help was just funny to me. I think it's awesome too. Yeah. No, I think it's fantastic. Yeah.
Right. A lot of old people don't use social media.
Right.
And how many people's kids don't know? Right.
No, he's I love watching the videos of him out jogging and stuff. So I apologize. I need to correct this slide before we send it out to you because I did not update the numbers for 2023 as far as the income and asset limit. But these are the different Medicare savings programs and what they help pay for as far as the Part A and B premiums. I'm going to skip to medication assistance for Medicare patients. We talked a little bit about it. I started, I think, 11 medication assistance programs within hospitals now since I started doing this in 2017. And so have gotten to be familiar with who I can sign up for which programs. And so these are just my own personal tips on how I classify Medicare patients when I'm enrolling them into patient assistance programs. But there are a subset of patients who have Part A only. And so I treat them as if they have no coverage for Part B or D drugs, or I treat them as their uninsured patients. So I apply for free drug for these patients. Then there are patients with Medicare Part A and B only who have that that unlimited 20% co-insurance for Part B drugs with no out-of-pocket max. If they had a Medicare Advantage plan, typically I would go to a foundation first to try to pick up that out-of-pocket, because I would want to cover their out-of-pocket expenses. I would want to fulfill that out-of-pocket max so that they could then go and get that surgery or go get that MRI and whatever else, and everything else would be paid for. But when they just have that unlimited 20%, a lot of times with infusions and injections, the co-insurance is too high. There's not enough money in the foundation funds to be able to do that. And so these patients, I find I usually have to apply for free drug on their behalf, at least until I can get them into maybe a Medicare Advantage plan where I can get a out-of-pocket max set for them. And then Medicare Advantage plan patients, they may need assistance to help with infusions or injections. Sometimes the oral prescriptions billed under Part B, and need help with the deductible or the 20% co-insurance until they hit their out-of-pocket max. Again, they're not eligible for manufacturer copay assistance programs, but I do look for open foundation assistance first. I use the PAN Fund Finder. You can sign yourself up for the PAN Fund Finder, and you can select individual disease state funds. And so if you have a patient who has ulcerative colitis, you can select that ulcerative colitis fund, and it'll text you or email you whenever that fund is open. So there's sometimes when those funds are closed, and so I'll enroll the patient into a free drug program, and I'll either put them on a wait list or I'll sign up for the alerts from PAN Fund Finder. And then once that disease state fund becomes open, then I'll go ahead and enroll them into the disease state fund. And then I can take them off of the free drug program. Yes.
I reiterate.
I was just going to reiterate on what you said. Definitely get the patients enrolled on the wait list. I deal with, like someone else in the back said, Ocrevus. It's extremely expensive. Unfortunately, there is not a lot of funding available for MS patients right now. But if you have them enroll on the wait list, they will get an email to let them know that the fund is open. Because if you try and keep a list of all these patients to contact, by the time the fund becomes available and you're trying to get them enrolled, it'll be closed.
Yeah.
Like it literally opens and closes same day. I've seen it happen. So please, please, please get them enrolled on the wait list.
The funds are extremely competitive, like to the point where I could receive that alert and I could go to start enrolling them, and the disease state fund will close while I'm in the middle of enrolling them. That's how competitive they are. Yes.
Patient Advocate Foundation, and both times it depleted funding for $7,500 in under an hour.
Yep.
No.
Yeah. So there's, this is where, like, if you work for a healthcare institution and your leadership is willing to pay for it, I think using the software like TaylorMed or Atlas or something like that is useful, because they can sometimes give you an advantage. They've got, I don't know what they call them, web crawlers or something, that can go and find where those disease state funds are open earlier than when you can get the alerts on your own. So it gives you a slight advantage.
I just wanted to say that also don't be afraid to build a relationship with these organizations that have these programs. They're not really allowed to tell you a week before it opens, but oftentimes they do know behind the scenes when they're going to open. And we work with a lot of extremely rare and sometimes ultra rare orphan diseases. And sometimes in those cases, if you build a good enough relationship with folks, I mean, this is kind of like what you said earlier, this is an inside scoop and you guys look like good people. So, don't tell anybody I said this, but the reality is though, that there are, a lot of times funds that kind of, they'll give you a heads up and they might say, you might want to be on the lookout maybe next Tuesday. They'll kind of give you a little bit of that if and sometimes a wink, wink and a twitch in the right direction can be life or death for your patient. So build a relationship.
Yeah. Thank you. That's good. Very good suggestion. Yeah. But the good thing is once you do get the patient in, then they're in, and then you can re-enroll them every year. But they typically, like, unless you don't do the re-enrollment paperwork, they don't lose access to that fund for any reason. So obviously if they've got part A, B, D in a supplement, they're not going to need assistance with any of the part B medications, but they could still need assistance with the part D medications because the supplements don't cover any of the part D drugs. So we oftentimes now see this in the specialty pharmacy arena where we have to apply on behalf of the patients for a lot of these high dollar drugs like the Humira and the biosimilars for Humira. But again, we same thing, we try to find foundation assistance first with those. Okay. See if this works. I'm going to try to get into the plan finder here. Has anybody had any experience with the plan finder before? Yeah. Okay. I can do this one-handed here. Okay, so you can create an account for the patient. The benefit of that is that if you have a patient who's on a lot of medications, it will then save those medications to the patient's account, so you don't have to type them in over and over again. But you can also just you can just do it by zip code. So I'm just going to use a zip code by my house. And it's kind of, so these are all the things that you can shop for and compare. You can do a Medicare Advantage, you can do a Part D plan, you can do a Medigap, you can do a Part D plus a Medigap. This is supposed to be for a patient to be able to use. Some patients I think could use it, but some patients probably need a little bit of help with it. And then I'm just going to say that I don't get any help from any of these programs. I definitely want to see the drug costs when I compare the plans. Okay, so since I'm a pharmacist, I'm just going to start picking some drugs here. I'll choose some generics. Anybody have any preferences? What is it? Wixella? Am I spelling it right?
IX.
Oh, do we want the brand name or we want the generic? Okay. Maybe we should use the brand name though to see what tier level it falls into. Let's pick a specialty med. Ooh. All right. I'm gonna go for the heavy hitter. Do they have Ocrevus? They don't have Ocrevus in there. Huh? Oh, that's right. Yep. Yep, that's why it's not in there. I think we could do Humira though. Oh yeah, and then let's do an insulin. Do Tresiva or Tarceva? Tarceva? Oh, am I not spelling it right?
It's down the list. TRESIBA. I think it's the fifth option.
This is what happens when you get pigeonholed in oncology.
The third one down.
Oh, there it is. Gotcha. Okay. We got a good selection here. Okay, done adding drugs. Got the zip code. Okay. Now we're going to select our pharmacies. So you can select up to 5 different pharmacies. I don't think I want to add that many, but just compare. Let's see. Okay. Then you can filter it by if I want to add vision, dental, or hearing, transportation. So let's just say I want to add vision benefits. Now let's skip that because I really want to focus on the prescription drug benefits. But just know that you can filter all of this. But so here's what comes up. So you can take a look at, and you can compare these side by side. And you can look at, here's what's going to be my total drug and premium cost. This is just for the rest of 2023. That's pretty high. However, we do have Humira in there though too, so. So let's just pick one so we can go through. Let's see if there's any 5-star plans. We could filter it that way. Sorry, it's hard typing with one hand. No plan. Okay. We'll go with 4-star. Okay. So let's just select this one. So you can look at the plan details before you enroll someone. So I'm looking at the monthly premium of $28. Here's my health. Thank you. My health premium, my drug premium, my Part D premium, all broken out. Here's my deductible. Remember, the max Part D deductible is $505 for 2023. My max out of pocket is $6,700 for in-network. And so it breaks down all of my copays for both primary care and specialists, all of my lab visits, inpatient, outpatient, sniff, and then you can look at the drug coverage. And now I can find my preferred pharmacies. My preferred in-network pharmacies is what I'm looking for.
Who does the rate? Who rates it to get the 5-star rating? Like who's the person that's saying you are a 5-star?
GMS.
Okay. Oh, okay.
I think so. I mean, I don't think there's any incentive for the members to inflate it if they're unhappy. Yeah. I mean, I know if I'm unhappy with my health plan, I'm saying something. Yeah. Yeah. Mhm. Yeah, it's kind of like the no news is good news type thing. So you can kind of see all across the board, these are all, because they're all preferred and in network, the drug costs are all pretty similar. But if I had an out of network or a non-preferred pharmacy, that's where you would see the cost difference, and that's what would allow you to kind of eliminate some of the pharmacies. But does this make sense, how to use the plan finder and how to use the tool?
Just one question. On the website, I noticed that it said from now until the end of the year. So if somebody's trying to plan for next year or budget and pick a plan accordingly, then do they use this website or do they have to use something else to be?
Yeah, so you won't be able to use it for next year until October 15th. Yeah. Mm-hmm. Yep. But you can, I mean, you can keep breaking it down and be more and more detailed and look specifically at like even, what the drug costs in each coverage phase. So, but also then you can look at the different extra benefits, which is really important to a lot of patients. And a lot of the plans come with dental, vision, and hearing packages. So, okay, so it looks like we are right. Like we've got 4 minutes left. So I appreciate you all hanging in there with me till the end, and for all of the discussion. And
Medigaps plan? Would there be something you would recommend to them for vision, dental?
yeah, there are additional riders. I don't think I have anything in particular that I recommend. I just kind of look for something in their area. So and I know there's a lot of private patient advocates, and I appreciate what you guys do and help, because you're helping them navigate the healthcare system, and it's a much needed job. So
Thank you so much, Geraldine. Does anybody have any more questions before we want to wrap up for our session? No? Oh, yeah.
I have one last question for you. Regarding pre-authorizations, is there anything on radar for Medicare A and B to implement some type of pre-authorization scheme?
I just know that there's a push for them to, well, the AMA is really pushing to, they've got several different initiatives to, one, reduce the number of prior authorizations. Then there's also the push for the gold card program, so that if the physician has a record of having so many approved prior authorizations or they're following clinical guidelines, that they won't have to apply for prior authorizations for their patients. So it would reduce the number of prior authorizations. So I think they're kind of making quite a bit of headway. But then from a legislation standpoint, there's, having to answer the prior authorization within a certain time frame. Because like right now with some companies, it's taking 7 to 10 days or sometimes even longer. I mean, some prior authorizations, sometimes it's taking 30 days to get an answer. So, I think they're pushing for even up to 48 hours. They want to turn around time. So it's the Medicare Advantage plans. Yeah. Yep.
Okay.
Thank you, everyone.
Thank you.